My name is Nina Garga. I am a neurologist at UCSF and the San Francisco VA Medical Center. I primarily work at the Veterans Hospital, but I'm affiliated with UCSF. Today I'm going to talk to you about hormonal effects on seizures and planning pregnancy. As a really quick overview, this talk is focused mostly on women, but some of what I'm saying can apply to men or to trans women as well. But in general, estrogen and progesterone are the two major hormones in women's bodies, and they act on certain parts of the brain where partial seizures can begin. Estrogen generally excites brain cells, which can lead to more seizures, and progesterone can actually inhibit or quiet down those brain cells, leading to fewer seizures. The way that progesterone typically does that is through one of its metabolites. It gets broken down in the body to something called a steroid called allopregnanolone, and that one tends to reduce seizures the most. The amount of estrogen and progesterones in your body, the direct amounts as well as the balance between them can really change and impact seizure frequency, especially in situations where the hormone levels may fluctuate. So, for example, during menstrual cycles, for people who are taking hormonal contraception to prevent pregnancy, when you are pregnant, when you hit menopause, or if you're taking hormones due to symptoms of menopause or for transgender care. This is a little bit hard to follow, but is a little graph of a typical menstrual cycle. On the x-axis at the bottom, we have the days of the cycle from 0 to 28, obviously understanding that some people have a cycle longer than 28 days. And it has a dotted line, or kind of like dashed line for estradiol over the course of that cycle, and then a solid line for progesterone. There's also a smaller green dotted line for allopregnanolone down here at the bottom. And what this is trying to show you is that during different times in the menstrual cycle, your estradiol levels can peak up high, which usually is what happens right before somebody ovulates. And then progesterone rises after that, basically to sustain the uterine lining in case somebody becomes pregnant, to sustain the embryo. So anytime the estrogen levels are higher than progesterone relatively or have a sudden rise, a person can be at higher risk of seizures. And for that reason, some women will notice that they have seizures at a very specific time during their cycle, when one of those changes can happen. There's a couple different times during the cycle when that can happen. The first time is when progesterone drops suddenly, which happens right at day 28 or 0, if you want to call it that, and right when you start to bleed. It can begin a few days before that or a few days after, but it's typically right around the time that you get your period. Another type is when the estrogen is rising very rapidly right before you ovulate. And then the third type is for people who miss an ovulation for a number of different reasons, and their progesterone doesn't rise as expected. The estrogen level remains high compared to the progesterone. So those are like the 3 different times during a cycle that a person can be more prone to seizures. It's different for each person, and depending on their own body chemistry and brain chemistry, which of those patterns might be present. And for some people, there is no pattern at all. The way we try to figure out if somebody has catamenial epilepsy, which is the name for seizures that come during a particular point in the cycle, is by tracking your periods on a calendar for 2 to 3 months to figure out if you have regular cycles or not. And then you also track your seizures on the same calendar, and then analyze the data with your doctor. And if a pattern emerges, your doctor can offer several different treatment options. There's a few strategies depending on your unique situation. One of them can be to increase the dose of your current seizure medicine on those high-risk days. Another can be to add on certain extra seizure medicines only during the high-risk days. Typically, people might use something like clobazam or acetazolamide in that situation. A third option is to stabilize hormone levels by taking continuous oral contraceptives. That's when people take birth control pills every day without taking a week off for bleeding, and basically gives them an even amount of hormones the whole time. And you can manipulate how much of that is estrogen and progesterone, and to make sure it works with you. And then the last strategy is to take natural or synthetic progesterone or some other hormones at very specific times during the cycle to kind of reduce that ratio of estrogen to progesterone. So those are all good options to talk to your doctor about if you want to try to track if you have catamenial epilepsy, or employ one of those strategies to treat those better. So I wanted to give a little bit of an overview on contraception. There's lots of different ways to prevent pregnancy if you're not ready to become a parent, or if you are a parent and aren't ready to have another child. Here, there's a little overview of different forms of contraception that can use hormones or not use hormones, and also permanent options like a tubal ligation or tying your tubes, or a vasectomy for the male partner. Hormones come in a lot of different formulations. The hormones can come as pills that are combined with estrogen and progesterone, or they can be progesterone-only pills. A patch, similarly, can be combined or just progesterone, and then there's a ring, which is typically combined. There's a shot you can get, which is a progesterone type of injection. There are implants that they can put under your skin that last for a couple of years. They have a particular type of progestin in them called etonogestrel. And then there can be plastic IUDs that have progestin coating. And an IUD is just an intrauterine device. It's something that's inserted by a family physician or by your obstetrician or gynecologist. The non-hormonal methods include barrier methods like condoms, diaphragms, sponges, and spermicides, and also can include an intrauterine device that doesn't have hormones on it, but has copper. So these are all potential options for people with epilepsy, but they have some pros and cons. Most importantly, some women taking contraceptives, the choice of the contraceptive can actually increase your seizures. And that kind of makes sense since we talked about the estrogen and progesterone ratios changing during cycles. Now, if you're taking something that has estrogen in it, you're at a little bit of a higher risk of having seizures, depending on your unique situation. Even the progesterone pills and implants kind of do something unexpected. Because it's a synthetic or a not natural progesterone that your body's not making, it doesn't metabolize to that specific type of progesterone that I mentioned before, allopregnanolone. And so those pills don't actually reduce seizures the way that allopregnanolone typically does. Now, the lowest risk contraceptive method for people with epilepsy include Depo-Provera and then progestin IUDs. On the opposite side, your anti-seizure medications can also reduce the effectiveness of your hormonal contraception because the hormones we make are metabolized by the liver, and whether they're your natural hormones or pills that you take, those can be metabolized quicker if you're on some certain anti-seizure medications, and that can increase the risk of an unintended pregnancy. So it's important to be mindful that if you are a woman who doesn't want to get pregnant right now, you should talk to your doctor to see if your current seizure medication and your current contraception are a good combination for you. Your strategies or options can include changing the seizure medication to avoid the ones that cause your body to metabolize hormones faster. You can also change your contraceptive method if you like the seizure medicine you're on and it's working really well for you. And you can use one of these other options that tend not to be so affected by seizure medications. So what about if you are planning pregnancy? How are hormones going to affect you, and what do you need to know to have a safe pregnancy? Probably the first and most important thing is that you have to talk about planning pregnancy with your doctor before you become pregnant, if at all possible, even if you're not planning for it right now. I mean, that could include talking to your doctor about it when you're a teenager who's started having periods. It doesn't have to wait until you're an adult or until you're in a relationship where you might want to have a pregnancy. Why is that important? Well, 65% of all pregnancies to women with epilepsy are unplanned. That's quite similar to the general population. And a lot of our seizure medications can carry a risk of harming a developing fetus and lead to some risks. We call that teratogenicity, or birth defects. And that highest risk of birth defects happens if the fetus is exposed to seizure medications in the first 4 to 8 weeks of pregnancy when the organs are developing. And that's typically before you even know you're pregnant, or once you know you're pregnant, but you're still waiting to get in to see your doctor to see how can I change my medicines to lower this risk. So for all of these reasons, you really want to start that conversation even before you want to get pregnant, because we can do things with you to optimize what you're taking to carry the lowest risk should you become pregnant, planned or unplanned in the future. And over 95% of pregnancies in women with epilepsy will result in a healthy baby if you work with your doctors to optimize the situation. We've made huge advances over the last 30 years with different medications and what we've learned from pregnancy registries that have really lowered that risk of birth defects tremendously. So if you are thinking about pregnancy, what are the main steps to do? First, you want to make sure that you do have the right diagnosis and that this is actually epilepsy. If there's any question about the diagnosis, it's worth talking to your doctor about whether any additional testing is important. Because if it turns out your diagnosis is not correct, then maybe you don't need to be on seizure medications at all, and you can avoid some of the risks that come with that. The next thing you want to do is make sure that you're taking a folic acid supplement. Now, even though in the United States, most foods are naturally fortified with folic acid, you want to be on more during pregnancy. And why is that? Well, we know that folic acid reduces the risk of birth defects in all people, and particularly in people with epilepsy. Taking folic acid through a pregnancy, particularly in those first few weeks before you might even know you're pregnant, can reduce the chances that any medications you're taking could cause harm to the fetus. And that means both reducing actual birth defects that you can see, but also cognitive effects, which basically means like your child's IQ as they grow older can be better if you took folic acid during pregnancy. The next thing you want to do is optimize your seizure control. You ideally want to do this about 6 months to a year before you're planning to be pregnant. You're going to want to choose medications and choose the dose of medications that will have the lowest risk to the developing fetus. And you have to, and once you've kind of gotten to that set point where you're not having harmful seizures and you're at the lowest dose necessary, you want to get your blood levels checked to figure out what is the amount in my blood for me particularly that controls seizures. And then you want to do a really good job of taking that medication. When you are considering pregnancy, there are a couple ways that pregnancy can increase seizure frequency. So first off, as we talked about before, there are changes in your hormones during a normal menstrual cycle, but also when you're pregnant, your body's got a lot of progesterone around, but it also has a lot of estrogen and other hormones around, and that can sometimes increase seizures. It also, as your body is changing, the concentration of seizure medication in your bloodstream can actually get lower because you're putting on some weight, you're putting on more fluids, and your liver is working faster. So you may need to be adjusting your medications as well. So having an idea that those are things that you'll have to address when you do get pregnant is nice to know ahead of time if you can. So when you are planning to get pregnant or find out you're pregnant, you want to make sure you're regularly seeing an epilepsy specialist and a high-risk obstetrician. It's okay if you have a general neurologist, but it's nice to have at least consulted with an epileptologist if possible. And the most important thing is to make sure that your epilepsy doctor and your obstetrician are talking to each other and communicating regularly. Usually we'll want to see you in the epilepsy clinic every month or so. Oh, there's my auto lights. Every month or so, and have your blood levels checked of your seizure medication. It's going to depend, the frequency with which we check that depends a little bit on which medicine you're taking and how likely it is to start dropping in its levels during your pregnancy. And what we often do is we'll start adjusting your dose during the second and the third trimesters, or even late in the first trimester, to a higher dose to maintain the blood level that worked for you before you were pregnant. The difficult thing is sometimes the body is clearing these medicines so fast that you actually have to take the medication 3 or 4 times a day by dividing it out more. So it's not easy, and it takes a lot of commitment and effort. But there's all sorts of apps and other strategies that you can use to stay on top of it. And then finally, stay on that folic acid supplement throughout the pregnancy. While we know that it has a really big impact in the first trimester, it probably has additional impacts during the second and third trimester that also help the health of your baby. So stay on that one. In fact, a lot of people will say, if you had to pick between a prenatal vitamin and folic acid supplement, the folic acid supplement is more important in this case, and you probably won't get nauseated from it, but ideally you would take both. So let's say you've gone through a pregnancy and you've delivered a beautiful baby. Things to keep in mind are that your seizure medication dose may have risen during your pregnancy to maintain that blood level. After you deliver, we have to lower that dose pretty rapidly. If we don't, what happens is your body is going to start metabolizing it slower. And then all of a sudden, you're going to have a really high blood level and feel all those signs and symptoms of toxicity or having too much medication, maybe being off balance and tired and confused. So we typically start lowering the dose within the first 2 weeks for certain medications and within the first month for others. Usually we try to target a higher dose than you were taking before you were pregnant because we all know that once you have a baby, you're going to be really sleep deprived. No matter how much help you've got in your home, there's going to be an impact. So we usually target just somewhere that's a little higher than what you took pre-pregnancy, but not as high as what you took during the pregnancy. I wanted to make a comment about breastfeeding. So, being a nursing mother can be a wonderful thing if it works for you. And it really is okay for most anti-seizure medications. It's safe. There's a couple of classes of medications where we're a little bit more cautious and monitor for sedation because just like the medication can travel to the fetus through the placenta when you're pregnant, it can travel in the breast milk as well. It usually travels a lot less through the breast milk to the baby than it does through the placenta during pregnancy. So it's not usually a major concern. It does become a concern sometimes for babies that are very premature because they can't clear the medications as readily. But in that kind of situation, you'll usually have very good support from the neonatal intensive care staff. A couple other just brief comments about caring for your baby. And this doesn't have to do with the hormones at all, but for women with epilepsy, it can help to sort of adapt your routine a little bit in the postpartum period, and while you have an infant to care for. It can be a little daunting to know that you're carrying a baby around, and you can be worried that I might have a seizure, and what if I fall down, and what if my baby gets hurt? So there's certain strategies we recommend, and you can find a lot of these through the epilepsy.com and the Epilepsy Foundation. But some examples could be changing diapers on the floor rather than using a changing table, or carrying your baby around the house in a stroller, pushing a stroller rather than carrying them in your arms. We'd also generally recommend against co-sleeping, just for prevention of SIDS, but particularly in case you were to have a seizure in your sleep so that you wouldn't unintentionally lay on top of your baby. So those are just some examples, and you can find a lot more information on the epilepsy.com and the Epilepsy Foundation website. Here, I wanted to put a quick plug for a great video that goes through a lot of the things that I talked about today. My colleague, Raquel Lopez out of University of Miami and the Miami VA and one of her patients put this together. It's about 11 minutes long, and it's basically, a beautiful little video interview of them discussing this patient's journey in deciding to get pregnant and going through a pregnancy and afterwards. And there's a link there, but if you just in your YouTube bar type in Veterans and Epilepsy Basic Training, Women's Issues, you can find it. So I am done very, very early. and wanted to open the floor for questions or any comments or from anybody who's here. And then just a couple of other things that I left out of the presentation. I mentioned earlier about menopause, that when women hit menopause, the levels of different hormones in their bodies will change. And you have a lot of different hormones that are competing with each other compared to what you have when you're in those childbearing potential years. Because of that, about a third of women will actually have better seizure control when they hit menopause. A third of them will have worse seizure control, and the last third will be about the same. So it's reasonable to meet with your doctor to talk about how to adjust your medications if you are experiencing a change in your seizure control that is not positive. So that's a little additional information.
Thanks, Dr. Garga. This is Paul. I was just logging in early to make sure that I could make the thing work on my computer.
Yes, I think we've all been doing that. Yes, I'm practicing my skill of being quiet long enough to give people a chance to get up the courage to ask a question.
Yeah. So I thought I'd just butt in while you're doing that, and now I'll butt back out.
No, it's okay. I think I'll stay on for about 2 or 3 more minutes. And then if people need a 3 or 4 minute bio break or a stretch break, then Dr. Garcia will start at a right around 12 noon for his slot. I'm also just going to add in the chat the link for the North American anti-epileptic drug pregnancy registry, in case anybody's curious about that. We have learned so much about which medications are safe and are the better options to use when women with epilepsy are pregnant. So here we go. I know we've all changed our lingo in the last year from saying anti-epileptic drugs to anti-seizure medications, but the registries haven't changed their names. So it's just www.aedpregnancyregistry.org.